I'm focusing on the driving force of modern radiation oncology, of the technology, and this is the dose delivery technology. For instance, proton therapy is something which we will have new in the next 5 years within the UK. And the second major player I envision is MRI-guided radiation therapy, where you integrate an MRI scanner directly with the dose delivery system. There is a very specific place in the UK, in Clatterbridge, who are treating uvular melanoma, intraocular tumors with protons of very low energy. And this was actually the first clinical facility or clinic-based facility in the world who has done this since 1989, I think. Now that the NHS has decided to fund 2 facilities with a £250 million budget, there will be new proton facilities at the Christie's in Manchester and UCLH in London. Then there will be a privately funded facility in Oxford, also a multi-country facility. And furthermore, it was recently announced that there are 3 single-room facilities in smaller hospitals, also put up by a private initiative. This technology is important for certain very specific tumors, which only very few have been identified. One of the major tumor site groups is pediatrics, because proton therapy will reduce the integral dose delivered to a patient when a tumor is treated by a factor of 2 or 3. And specifically for young patients, that is very important for the induction of secondary cancers in order to reduce this risk. This is the physics. If protons are shot into your body, you can control the energy of the protons, and the energy determines how far these protons penetrate into tissue. And because there's no dose behind the dose fall-off, there's a characteristic depth dose called the Bragg peak. That means there's low dose at the entrance, and where the particles stop, there is quite a bit of dose. And this peak, if you tailor it directly into the tumor, then there is no exit dose, and therefore there's less integral dose when you compare it with photons. The Christie's in Manchester is planning to treat in 2018 and UCLH 1 year later. I think in the moment it is very similar. It would cover in the order of 1% of the radiotherapy patients treated in the UK. So it is estimated both facilities will treat about 1,500 patients per year in its full operational status. With respect to Europe, it's quite diverse in the moment. In Germany, there is a heavy ion facility running and 2 proton facilities, or even 3 now. They're really developing, but this is one of the countries where you have most of the hadron therapy. In the Netherlands, there are 4 initiatives who are planning to have new facilities, but they are in the planning stage. There's also something going on in Sweden. A facility will come soon. I think overall we are in the right direction to figure out what is the most clinically appropriate treatment site for these very sophisticated radiation therapy technologies. The magnetic MRI-guided radiation therapy, yes, this is something completely new, because what we need to know, and that is also true for protons, and unfortunately that is not that much developed there either, that we have to see what we want to treat at the time of the treatment. And in the moment we have X-ray based technology at our linear accelerators. And for many clinical indications, we just see hazy electron clouds. But with an integrated MRI scanner, we can see extremely good soft tissue contrast. We can do imaging all the time. That means there's no extra radiation burden for the patient. So we can determine the motion, organ-induced, breathing-induced organ motion, for instance, and we can adapt in real time our treatment to the variations of the anatomy. And I think this is really new and will be a step change in the practice of radiation oncology in the future. Well, it's always in radiation therapy, as in radiation oncology, we want to opening the therapeutic windows. So if you are reducing side effects, then that gives you the opportunity to dose escalate and to improve tumor control. And this balance is this therapeutic window will open. And to what extent and for what clinical indication it is best to be used has to be figured out by clinical studies in the clinical system. Yes, the initial investment in hardware for protons is expensive. For the MRI-guided radiation therapy, we are doing this with the so-called MR-Linac in the UK, which is introduced through a consortium of 7 international partners. So we had to pay a nominal price, but just for this for this specific arrangement to translate this into the clinic and demonstrate its clinical usefulness. So the final price, of course, of these technology depends always on how broadly they can be disseminated. You know, in the moment, we are among the first 7 sites for the MR-Linac worldwide, and yeah, these are unique systems. But I can envision in the order of 5 to 10 years that, at least for the MR-Linac technology, it can be very compatible in price to a high-end system, or maybe in a factor of 2 or so more price. So this depends on how valuable we can demonstrate this technology is. In order to exploit these investments in the hardware delivery, the dose delivery systems, it is absolutely necessary that we have state-of-the-art software components which interlink, for instance, treatment planning software with dose delivery in order so that we can take images while the patient is treated, use this information in real time to re-optimize our treatment plan, and then deliver this re-optimized treatment plan with the hardware system. So this feedback loop has to be fast and smooth, and there one needs excellent software modules. Yeah, it's in my view, it's very important that these highly advanced radiation therapy technology centers work very closely together, share a common infrastructure, data exchange, design clinical trials under the appropriate leadership, depending on what clinical site it is and which hospital is the leading facility in the UK in order to coordinate these trials best.